So huge compliments to Dr. Srinivas Kumar and his team for organizing a wonderful meeting after long 2 bad years of lockdown. I was luckily there yesterday and it was a great session on structural heart. So today is the coronary day and here we are showing you a bifurcation case with calcium. Can you run this is the angiogram of the 87-year-old Mr. Huda.
Show the angiogram,
to
please.
us as a case of unstable angina. Show the angio.
Yeah, we can see it.
That's the angio. So he is an octogenarian who had an MI in 2007 inferior wall, an inferior wall leading to RCA occlusion, which is supplying to an akinetic segment. EF is 40%, and we have a bifurcation lesion here. It looks like trifurcation on the spider view.
Our patients are also simulating West, it looks, sir. We saw.
Circumflex.
Our patients are also simulating West, okay. I am saying, because just now we saw a 92-year-old lady done, now you're showing a 86-year-old person. Please go ahead, sorry.
Yes, so he's truly an octogenarian, 87. So in this angiogram on spider view, we see that the distal left main has significant plaque. Nevertheless, we'll assess it by doing ultrasound. It also has proximal LAD disease, which is extending up to the mid LAD, as we see in the other view. We'll come further. And there's a large sizable ramus, which has proximal long disease. Go to the next one. This shows that, we checked some IVS runs here. Go further.
I'm joined by Dr. Ajay Kitane from Colombia. We are here to moderate the case.
Oh, wow, Kitane. Welcome, Ajay. Yeah, it's a pleasure to have you on this case. So, can you just show me the IVS? On IVS interrogation, we found that LAD had disease, a significant plaque extending up to the mid LAD and distally. And to our surprise, the calcium, which was not seen much on the angiogram, shows a napkin ring calcification at the proximal LAD. And it is there that we change our plan to do a rotablation for LAD before we deploy stents in this LAD. We did not carry out, we did carry out IVS for the ramus also, which again shows, can you go to the ramus IVS? Which again shows some calcific and fibrotic plaque in the proximal part, and the distal left main measurements are given to us as 4.2 or 4.3. And the plaque extends up to the mid shaft of left main. So we changed the strategy here and we went to do the rotablation of LAD. Go further. So while you guys were busy having lunch and the program got delayed, so we carried out a rotablation runs in the meantime and did some pre-dilatation of the ramus also before we went on to do rota. And we picked up a 1.75 millimeter burr here, going by the size of the vessel on IVS. And thereafter some polishing run, go further, at the speed of 160 or 170. And then we carried out another IVS run to show that what we have achieved after doing rotablation. And we could see clear reverberations at some points in this vessel, which is a hallmark of a successful rotablation. And further going on, we could also see the vessel looks nice and we could also measure the size of this vessel. And thereafter, we had to remove a wire from ramus while doing rota for this vessel because we can't perform rota with 2 wires and there's always a fear of intertwining. And then of course we go further. We rewired the ramus, which was pre-dilated, and go further. And this is what we had achieved after rota. And so we decided to fix the distal and mid LAD first with a long stent. So we took a 3.548 for the mid and distal LAD. And we have fixed the distal LAD. The patient's hemodynamics are good. And with me is my colleague Dr. Satbir Singh and Dr. Amit Goyal, who are assisting me, and of course Bipin and the team from Medtronic. So after this, the plan is now to fix the left main to LAD, and my approach of bifurcation here is going to be provisional. Though the ramus is a sizable branch, but the take of this ramus is pretty good to me and I can rewire it always after doing a crossover left main to LAD. So I'm going to do a crossover left main to LAD and my size of stent is 422 Onyx. And Onyx, as you know, is the stent which is also being used in the EBC1 trial, which has recently been published. which gives us a guidance about the strategy for doing left main or left main bifurcations. And we know for sure that the results of that trial show that provisional versus elective two-stent strategies have this similar outcomes. So my approach for the sake of simplicity is the provisional approach, where I'm doing now left main crossover 422 onyx from left main to LED, which already has a stent of 3.5 millimeter, which has been post-dilated. Give me a 422. I leave Dr. Shri Kumar to you for question answers and your valuable comments on this summary which I have told you so far.
Thank you, Doctor. You have made mid-LED look better. Now I think you are trying to cover the ostial LED and distal left main with a crossover stent. LCX ostium looks free from disease. Hopefully we shouldn't have any trouble there, but you are still protecting LCX with the wire and then doing bed preparation is already done. Left main distal portion ostial LED is dilated with a balloon. What size balloon you said, sir?
We did a 3.5 millimeter balloon.
Okay. So now you're taking 4 into
left main and proximal LED
4 into 22 onyx, you said.
22 onyx.
Okay.
Yeah.
So the plan
Because
is not to come onto the
sufficient
ostium.
length in
There are two
left main
schools of
shaft.
thought, Ajay, here. Some
No,
people recommend
Ostium
directly
is-
coming into the
ostium
ostium
is clean.
and tackling everything. But French guys say that suppose the ostium is free from disease, you can still get away by not doing it. What is your
Ostium
practice?
is clean for me,
Yeah,
so
I don't come all the way back as long as I can have enough room to pot the left main, because I just worry that you're going to stick out and there's no reason to do it unless you have to. But you do need enough room to pot. If you don't do the pot, then you're going to have malapposition.
Other aspect is, apart from the size for a pot, the proximal vessel at the ostium and the proximal vessel should be totally free from disease. If you have mild disease, again, you might tend to dissect. I think that is another important reason for consideration.
That's right.
We want to come all the way to ostium. Okay, sir. I think we are able to see. Go ahead. Again, as
So
the sir
I
is doing
completely
it, it's
agree with
very
Ajay
important
that
to
yes, you
check
should
the
leave
ostial
sufficient
location in
length.
cranial views, eleocranial and epicranial. He's in epicranial. Probably
Exactly.
should also check in eleocranial once before we deploy the ostial, because that's the best.
yeah, go to allocranial. Yeah. Although my plan is not to cover the ostium here,
Achha,
but
then
that's
it's
the
okay.
best view to see the
If you are,
ostium.
but
both.
you should be
Yeah.
just sure
But
that
take
segment
one
what you are
shot
leaving
here.
is free
But I
from
want to
disease.
stay clean of ostium, yeah.
Then
It's
if you are
free
not
from
doing
disease.
it,
I
you
have
can
checked
go
it on
little distally
ultrasound,
also.
IVS, and yeah,
Looks pretty
yeah,
good,
yeah.
though.
Go to caudal.
Okay.
And I have seen that the ostium of circumflex is clean on IVS. So that gives me a lot of breathing space where I deal only with ramus. Go here. So I'm going with 422 telescoped into the distal LED stent. Go. Blow it. Yeah. That's it. So we've gone to 14. Okay. 14 is our pressures. Deflate. Yeah. And I do a little push on this balloon so as to dilate the interface. Go further. And give me a 4.5 10 balloon. Okay. Deflate. So at this stage, pot is required. The pot will serve you two things. It will prevent any rewiring from going by the side of the stent. It will facilitate your passage into the side branch, which is ramus here. And of course, the technique of doing pot is that your distal dot of a balloon should be at the carina and no further. Otherwise, it will defeat the whole purpose of doing a pot. It will lead to plaque prolapse into the side branch. So now I'm ready for a pot.
That's why I
With
think what
410
Ajay was mentioning was very
non-compliant-
important. Either you
4.5,
can't
10,
cross the
non-compliant
carina
balloon.
and you can't come to proximally where the stent is not there. You need to have right size balloon. You're taking 4.5 into 6. What was the
Exactly.
balloon?
I am 4.5 into 10 is the balloon
10,
because I have
okay.
sufficient length of stent
Okay.
in the shaft of
Here
left main.
anyway you have space
So
distally.
I'll do a pot here. That's it. So here I go, and I'll cross check on my angiogram also as to what is the takeoff of the branch. So that's my balloon. This step is very important, especially for our younger generation of budding cardiologists, that the steps on bifurcation stenting. Now a little further, go. And I could have taken a bigger balloon also, the longer one. Go. So we are at 10, 12, 14, 16, 18. Deflate. And some approximation on the proximal stent also. Go here. Yeah. 10, 12, 14, 16, 18, 20. Deflate. Yeah. And that's it. Patient is doing fine. He tolerates these inflations well. And did you see the IVS runs, Dr. Shri Kumar?
Yeah,
Srinivas?
before one where we have seen, now I think post left main stent you will do IVS run.
Before and after rota, yeah. Okay. So go to spider. So I take a check shoot here and then recross into the ramus, which fortunately for me is flowing nicely. Give me another wire. So give me a pilot 50.
So what is your policy when you do crossover, even without any problem in LCX, you would always would like to kiss, or we were thinking if everything is fine, we could avoid it. That's what Ajay also agreed before.
That's a good question, because the data says that there's no data to prove that you should always recross into the healthy circumflex and with kissing balloon. So my strategy is here to address the ramus, and I might not cross into the circumflex here. Nevertheless, I'll capture a post stenting run also to see how the mouth of circumflex looks on IVS. Go.
The definite indication is, as you agree, there's a stenosis and then also slow flow or some resection. All that will definitely intervene. Without any of these, it's anybody's choice. But if always, if possible, you try to avoid working too much on the osteal LCX, because that's the commonest area of trouble and follow-up. Antonio Colombo says when you did left main bifurcation, somebody comes back with stenosis, it will be invariably LCX osteo.
Yeah, so here I'm trying to go into the circumflex, the ramus now. That's the circumflex. And a little further I have a ramus. Just don't move, Babaji. So I'm recrossing into the ramus now. Go to caudal, RA caudal. The wire is always kept there. That gives me guidance as to where I have to cross. And now I'll remove the trapped wire from here. And as you recall, I have already pre-dilated this vessel. Yeah. Oh, sorry. Yeah, go to spider further. It came out. Yeah. But the crossing, the rewiring is pretty easy here. Go to spider. Go to caudal, RA caudal. Any suggestions in the middle of this case?
No, you're doing
now
it very
I'll remove
smoothly
the
and
trapped
nicely.
wire here. The trapped wire is removed because it gave me guidance as to where to cross, recross. And now get me another balloon of 1.5. So I'll take the tiniest balloon to recross into this ramus. And I would follow the pot balloon repot. And not perhaps the kissing here, depending on the size of this vessel. You agree with that approach?
Yeah. Go ahead.
Yeah, I think that's very reasonable.
First pot I had done, and I'll do the balloon, open the struts of that vessel, and then I see if I need a stand there or not. And my strategy is going to be tap there, because I'm on provisional path. Go further. Suck. So, okay.
So this is the previously used balloon or
So
new?
here I go. Yeah. This is a new balloon. It's a live case, so all new balloons.
Even otherwise, I think the way you're
Okay,
crossing
10,
the
12,
struts, you should
14,
always
16,
take a new
18.
balloon instead of
Deflate.
even if you use old balloon.
You
As
should
such,
always take a new
the
balloon. Go
utility
one
of
more.
old balloons have come down significantly.
Go. 10, 12. All right, deflate. Give me another one, semi-compliant to 210. So this is nicely opened now. After this, I'll do a repot on the left main, and I'm done with this case thereafter. One more, 2 millimeter. So Dr. Ajay Kirtane should guide me as to, could it have been done any different way?
No, I
this
think
particular case.
I think the way you're doing it is the way I would do it. It's elegant. You try to avoid multiple stents. It is interesting,
complexity.
you know, for bifurcations, the definition 2 was a 2-stent with a DK crush versus provisional and showed a benefit,
Give
and
me
then,
a
you know, EBC
four-
main goes the
4.5.
other way. So I think there's some controversy about it. I think for most people, though, if there's significant length of disease in the side
Go
branch,
further.
then that's where you're going to opt for a 2-stent
That's it.
strategy.
Right. Right. Thank you so much. And this is another 2.5 balloon at 12-14 atmosphere. So I've nicely opened, if deflate. One more. Deflate, yeah. Now, as Dr. Shri Kumar pointed out, go one more. That any only indication of using another stent here would be deflate. If the disease is significant or there's a slow flow or there's changes on ECG, ischemia, then I would put a tap. Otherwise, I'll leave it alone because single stent strategy is always better in the long run than the 2 stents. Give me the balloon 4.5. So now I'm doing the pot, and thereafter if the time permits, I'll show you the final IVS run on this. Another highlight of this case is that I used a 1.75 burr here because the LED was quite sizable, whereas the default size is 1.5 in most of our cases. Suck. I'm doing the final report and we'll show you the IVS thereafter. Go. 10, 12, 14, 16, 18, 20. Deflate. So that's with 4.5. Ritu, are you ready with the catheter? So I used Onyx stent here as per the EBC one, where this was the stent used, and
There's a new study, interesting name,
So when it
Rolex
comes to
study
left main,
also came with Onyx, not Rolex watch, but Rolex
wow.
study. They said
Wow.
this bigger size, the Onyx can expand well
sorry.
to 5.2 size, and they showed about 450 patient study and showed results were quite good. But Mary Claude said at the end still there are follow-up there
And
about
this wire is out
2% event rates, which is still
Give
high
me
in
the
today's
IVS.
still
Yeah.
we,
Give me the
we
IVS.
should be doing this carefully. And,
So I'll give you an
with
IVS
proper
run
image
now.
guidance.
Yeah, that's it.
Dr. Ajit sir, you'd always
There was earlier
what is
damping
your
of
strategy
pressure
when
here, but
when you do crossover? What is your strategy? As I said, we'll do it only if you want to, if it is absolutely essential to indicate. The same
Yeah,
thing.
I don't open it unless absolutely necessary. There's a
You are doing IVAS, sir, now?
so this is, the final run of IVS, and then I'm done. You can then move to Mumbai for Ajit Menon's case. Okay. So that's the straight. Keep it straight. Come closer. Come closer. Yeah. So here we go. Come closer. Come closer. Here we go. Go. So that's the final IBS run. Yeah. That's the stent. Nicely opposed. Are you seeing the live IBS run?
Yes.
Dr. Srinivas?
Yes.
Yeah, okay. This all looks good. Nicely opposed. And
Nice expansion.
that's the
Everything
interface.
looks great.
Nice. Yeah. And the left main looks very nice. Perfect position.
So Srinivas, I have a question for you.
Disengaging
So
my guide and the
every single one of the cases live has had some imaging used. Is this standard or is this just for transmissions?
Oh, no, it's not like that. Left main, I think we should appreciate the significant number of centers are using imaging, but not like for all other vessels.
That's it.
Because we have seen some of complex cases, left main more commonly, everybody used imaging. But I would say it is positively increasing, but maybe 20%.
Okay. That looks great.
Great.
Yes, in my practice, when I'm doing a left main, I invariably 90% of the times would use the IVS because it gives me a lot of guidance about the size and of course planning my approach for these cases. The Ramus is flowing fine and LED looks good. Any other questions on this before we
No,
close
very
it?
well done to you and your team.
Thank you. Any final comments, Anand, Sajid sir?
Thank you
Anybody
so much.
Want to say any
I
comment?
think it's a nice result, Subhash. So, congratulations. Let's
Right.
give him a big hand.
Thank,
Yeah, wonderful.
thank you so much. Thanks.
Thank you, sir.
And I'm privileged to be part of your meeting.
Yeah,
It's
thank you,
wonderfully
sir.
done.